developing the upper arch, he still has no growth. Remember, this boy should have been growing vertical, anterior, posteriorly, and downwards. He's not growing at all. Okay, so from here to here, and I do have the superimpositions you will see at the end. So from here to here, the lower incisors flared completely. So now I have no overjet. I have to recover my overjet. So again, I go to my 2x4 because I need more space still. This canine is out. Now I recover all the spaces that I need for the permanent upper dentition. The lower dentition, I don't have the space. So whatever I do, I need to distalize lower molars, upright, and intrude. If I don't have space, I don't bond brackets. So I'm not bonding the center incisors yet until I gain the space. So he does have a MOAL in the lower arch with class 3 elastics. I recover the overjet that I had lost, which I lost my overjet, of course, trying to bring the premolars back so this canine would come in. And trust me, when you open spaces, canines come in on their own. Rotated teeth derotate and the canines come in. So we managed to develop the upper arch. Here's the lower arch, still some spaces, but not enough to bond my incisors. And we can see here how he was and how the molars were uprighted and intruded, because every uprighting generates extrusion. So whatever mechanics I use, I have to be able to intrude upright and possibly distalize. So gaining space for all the lower teeth. Here I am hoping and begging that he doesn't have third molars, right? Because you can see the posterior discrepancy. Like I told you, this boy is not growing how he should. I do manage to gain my overjet, but my class 3 elastics protruded my upper incisors. So now I have to retract everybody. So I love to use the mulligan overlay when possible. Here's my upper mulligan, lower MOAL, and I finally start leveling the lower teeth. You can see here the upper MOAL. Still don't bond my lower incisors, not enough space. Upper arch is looking better, not perfect. Lower arch needs to be developed also. So here again, the upper arch. This is 18 months down the road. Now with braces, finally I bond lower incisors, and you can see that now I have space. I really don't like my incisors to flare at all. They already flared. I uprighted them. I don't want them to go back. So here's the upper arch development. Here's the lower arch. It's almost there now, coordinating arches. And at this point, so initial, and at this point, here's the upper arch, already symmetric. It was asymmetric. Now there's symmetry. It's been developed. And we're still evaluating the growth. The boy has not grown. He's still very short. He's taking growth hormones, okay? And he's been taking growth hormones for 1.5 years now. No growth. And if you look in the literature, when they do take growth hormones, they go into a class 3. If you read every literature out there, the patients that take growth hormones usually grow into a class 3. The most important thing for me in this boy was to control the vertical, because he was growing the little he was growing was vertical, a little bit. And the vertical control with conventional orthodontics, it says that usually what they do is they retract the maxilla, but they're unaware of the amount of vertical growth that the patient still has. This is how we grow vertical, right? So they think that by wearing a high pool, they're inclining more the occlusal plane. They're turning the patient into a greater class 2 instead of treating the class 2. And here's the review of the literature. It's saying that both fixed and functional appliances treatment for class 2 division 1 malocclusion are accompanied by exaggerated vertical facial growth. Okay, so these patients that have exaggerated vertical growth, when they grow, they go into growth, they will grow more vertical than anyone. They have excess maxillary height. Okay, anterior excess maxillary height everywhere, but special anteriorly. And so there are several short-term use studies with biplanes and high pool headgears that show reduction in vertical height, but there are no long-term studies that suggest that these changes are other than temporary, and they're not, because there are no changes. They're not creating changes. Nowadays, on a class 2, it would be enough to flatten the occlusal plane and allow the mandible to come forward, using the patient growth. This boy has no growth. He hasn't been growing, very, very little. And so I have to do something with my mechanics to allow the mandible to come forward. And in these high angle cases, this is what we have. This is what I'm talking about, excess maxillary height. So for this boy at this point, I am trying to change this, redirect his growth. If he has any very little, I want to redirect. I want him to grow posteriorly. I don't want the anterior facial height to be greater because it will be, he'll grow more vertical. It's already high, but I want the posterior facial height, or actually the posterior height to grow. So the ramus, this is what he doesn't have. So we're doing the full arch intrusion on him. Here's the lower arch. And you can see here, this is 4 years with me. This is the first x-ray at 11, at 10. This is at 14. He has no signs of growth yet. Taking growth hormone. It's a very difficult case. You can see a point came forward. So we developed the upper arch. And at this moment, the mother is very unhappy with the treatment, with the growth hormone. They tell me, remove everything. I'm not done with the treatment. They said, remove everything. He needs a new MRI because he's not growing. But I think you can see here that from his initial, what would have been the normal growth, and you can see the flattening of the occlusal plane and managing to bring, this is not perfect yet, to bring pogonium forward and bring the mandible forward. This was -7 millimeters, which was expected at the age, and here's +2 millimeters according to what everybody knows, it's N perpendicular. So to bring it +2 forward, and you can see here in the superimpositions that the body of the mandible barely grew. Nothing was seen of growth, but the ramus did grow. Okay, so this is how you treat a class 2. You have to stimulate the growth and the remodeling of the condyle. So if people say that condyles don't grow, they grow. We just don't know how to stimulate the growth. Okay, so unfortunately, I never saw this boy again. I've asked and called the aunt and the uncle, the parents, to bring him back. This is the day he left. And so this is initial and the final. Here's his face. You can see he's very little. There hasn't been that much change. So this is the day that we had to remove everything so he could go for another MRI. And to my surprise, so here's the initial. Here's the follow-up in 4 years. So 4 years of pictures. You can see that he's very little still. He was crying. He was very unhappy. He wanted braces off. He wanted everything off. He was very little. I found this picture of him the other day on Facebook. I've written to the mom to bring him back. I have had no answer, unfortunately. But to me, what I can see is that nothing else has been done to the boy. Hopefully he did grow. I can tell that he grew a little bit. He seems to be a little bit taller than he was. And so I really wish he would come back. So malocclusions cannot be simply considered as an abnormal skeletal growth, but rather a functional abnormality as well. Okay? Malocclusions are not genetically dictated. Okay? There's a lot of play of epigenetics. That is good news for us, which means we can treat malocclusions and we can redirect growth. Okay? Here are my two dear professors, Sato and Slaviček, and what they say is right. Occlusion is treated with concepts, not with techniques. Okay? Thank you very much. This is all for today. Let's go for the questions.
So, thank you, Daniela. How are you? That's right. Okay. Thank you for this wonderful lecture, and greetings from Vienna to Sao Paulo. Okay.
Thank you.
We have a couple of questions, and it's my honor to ask it to you. So, let's go here. The first one would be, do you take all these diagnostic records for every single patient? Isn't it a bit costly for a routine protocol rather than restricting all these records to DMDs?
Yes, I take all of these records for every patient because if I don't know what's going on, if I don't know, there's some TMD patients that are subclinical, right? They're symptomatic, quote unquote, until you palpate them. And then they tell you that they have pain because either it was acute pain, it's become chronic. We have children with displaced discs forward with reduction. That's the first sign of a TMD. And we don't know. If we don't do every single step, this is called, in my country, documentation. It's a document, and you can be sued in my country for malpractice. So yes, I do everything. This is very important. If I don't know what's going on, how do I know what I'm going to treat, what I have to treat? So I do this for every patient, yes.
Okay, thank you. So the next question would be, how do you decide the vertical height or the vertical dimension of a splint? I think it was belonged to the one girl case you showed pretty at the beginning.
Okay, it varies from patient to patient. It depends on what the radiologist gives me on the palpation, and we do controlled mandibular repositioning, right? Where we're going to have test bites and test on the patient. And once you work on the curve or you work on the hinge axis, verticalization is just, you're verticalizing the splint. It depends on what the patient needs. Usually I go by the mandibular repositioning and the palpation. Sometimes they need little vertical, sometimes they need more vertical.
Okay. So then there is another question, a little longer question. Okay, you have mentioned that you treat most, but not all of class 3s with class 2 elastics. What is your criteria to treat class 2 and class 3 with this concept of changing occlusal plane? In other words, what are the limitations in treating by using this concept?
Okay, elastic is not a concept. Elastic is a guide. They don't treat for us, they guide us. Okay, we use whatever. Unfortunately, we call them class 2 and class 3 elastics because they were called that way. That's the name they have. But I use many elastics. When I need to change the occlusal plane to rotate on a class 3 low angle, I always use class 3 elastics. But on a class 3 high angle, I don't need that rotation, that clockwise rotation. So I will not use any kind of class 3 elastics, or class 2 elastics on a high angle class 3. It depends. There is no criteria. It's read and react. You look at the morphological characteristics of a patient, and then you decide how you're going to treat. But remember, it's not the elastics. You can use no elastics and treat the patient.
Okay, thank you very much. So there is another question. Yesterday, Professor Sato said in his lecture that orthognathic surgery is also a compensation, and that's why he don't do surgery. What do you think about surgery?
I think, like I showed in 2 cases, there are patients that need surgery. The patient that was born without both condyles, or like you saw those 2 patients with the syndrome. They can't function, they can't eat, so they need prosthesis. The only thing that I'm afraid of is, number 1, orthognathic surgeries are not 100%. Okay, they do relapse. It's much easier to generate condyle compression to the condyles after orthognathic surgery because they have to reposition with their hands. My question is, how can you reposition with your hand a condyle and a disc in the fossa during surgical act? There's no way. So there are many. If orthognathic surgery is needed, if it's needed, like I said, if the patient says, I hate my face, they need plastic surgery. So.
Okay. Another question. Could you tell once again how you change the occlusal plane in class 2s and class 3s?
Of course. On a class 2, usually you have a very inclined posterior occlusal plane. So the whole idea is to flatten the posterior occlusal plane. So you need to, and the lower teeth are extruded, the lower molars and tip to the mesial. So you'd have to upright them and intrude the lower and upright the upper that are tipped to the distal and extrude. So that would be on a class 2, flatten the occlusal plane. On a class 3, it's the opposite. The most extruded tooth is usually the first premolar, the upper. So we probably do the reverse on a class 3. You have to incline the occlusal plane.
Then another question would be, can you stimulate condylar growth in adults?
Of course. You can, it's called,
of course.
yes, it's called adaptive remodeling. It will not grow like a child, but it will remodel. Yes, you can. It's a secondary growth site that can be stimulated. Yes.
Okay. And there is a couple of questions regarding occlusograms. Could you evaluate again what is occlusograms and maybe a little bit about the technique and what it is?
Okay.
People doesn't seem to know about occlusogram.
Okay, I'm so sorry. Occlusograms is a very thin sheet of wax. Okay. Usually they use it for prosthesis. There's rugosity, so it's green. It's usually green, and they use it for the palate to give the shape and the feel of the palate. Very, very thin. And what you do is, I prefer to use the Hanau tweezers that you saw. And you're going to tell your patient, he's sitting in your chair, and you just want to evaluate how the patient is functioning according to the teeth at the time, not the articulation, but the guides and interferences. So sitting in my chair, I use it a lot when I'm doing orthodontic treatment to check if the cusps are touching the fossas and how they're functioning. So you do basically 5 movements. The first is ICP, which is intercuspal position, which is, okay, let's call it maximal intercuspation. Okay, just tell the patient, I position it on the upper arch and tell the patient to bite. And I can see where the occlusogram is cut, right, is where it's really touching. And then you do protrusion, you do bruxing in the chair, then you do lateral right and lateral left. It will give you at least an overview of the function before the condylography. It's right there.
Thank you very much, Daniela. We have a lot of more questions. This is too much to answer now here live, so Daniela will get all the list of the questions, and she will answer hopefully by typing and sending it, and we will upload it to our webpage, so you're going to find it within the next few days on the Visit webpage. So thank you very much, Daniela, for this wonderful lecture. Thank you for all attendance all around the world for listening, and we are hoping to see you soon again in one of our Visit education seminars. Thank you very much, and have a great morning, great time, a great day, or a great evening. Bye-bye.
Thank you very much. Bye-bye.
Ciao.